Hey, GLP-1 Plus SideZ community. Before we jump into the podcast, please take the time to leave us a 5-star review on whatever audio platform you're listening to the podcast on. Share your story and how the podcast has helped you. This will help us get referred up in the audio platform so that we can reach more people that need our help, our support, and guidance from our doctors. Help us get loud and change things. Are you interested in understanding GLP-1 medications like Ozempic, wegovy, or Mounjaro? Then join us on the Plus SideZ Cracking the Obesity Code, the groundbreaking podcast helping people change their lives one episode at a time. The Plus SideZ Podcast is a disruptor. We're breaking down barriers, smashing stereotypes, and sharing inspiring stories that'll leave you feeling informed and empowered. Join us every week to learn from doctors who are specialists around GLP-1 medications like Ozempic, wegovy, and Mounjaro. They'll provide you with science and facts to validate these incredible stories. But that's not all. We'll also bring you the voices of the GLP-1 Mounjaro TikTok community, real people who face the challenges of obesity-related diseases and disorders and discovered the incredible plus sides of GLP-1 medications. Our episodes are filled with heartwarming stories, laughter, and moments of triumph. You'll connect with our amazing community members who are reclaiming their health and experiencing their fullest lives. Are you ready to embark on a journey of discovery and empowerment? Tune in to the Plus SideZ Cracking the Obesity Code, and together we'll change the narrative around obesity and end the stigma. Subscribe now on YouTube or your favorite podcast platform and join our incredible community. Let's celebrate the plus sides of life together, because every story deserves to be heard. Every life deserves to shine, and everyone deserves access to expert knowledge and medication. The Plus SideZ Podcast. You're not alone. It's not your fault.
"20 seconds a week to lose 20% of your weight in a year with diet and exercise." That's the power of GLP-1s through Ro. Ro helps find the medication that's right for you, based on cost, availability, and your weight loss goals. Losing weight with GLP-1s is possible through Ro.
Welcome to the Plus SideZ Podcast.
It's an exciting day
It
for the
is.
Plus SideZ Podcast.
It is. And
Welcome,
why?
welcome.
Because we are, I don't know if you guys have noticed lately, but we are trying to branch. I think that being on this journey, on a GLP-1 medication and going through and realizing this isn't about weight loss at all. It's about health. It's about treating your disease, and it's not your fault, that you're not alone, and all of these different things. We've also learned a lot about the holes in our healthcare system and the issues with accessibility and affordability.
Yes.
And Kat and I and Bear, who run the
Yep.
podcast, very much feel a calling to shed light on this and try to get loud and change things and try to combat the misinformation that's out there with as much education and knowledge as possible. And so we're going to have more guests on to shed light on this problem and try to come up with solutions. I don't know what's going to come of this, but your engagement in this content and you sharing this out to other people to help others is our goal. Because I think we all know that a lot of times people don't want us talking about these things, and that's just too damn bad. So we're so glad to have you with us today. Yay!
Yeah.
We'll go two quick intros. I'm Kim Carlos. If you don't know me, this is the Plus SideZ Podcast, where we focus on really helping a lot of people understand all the information around the available, not just medications, but treatments for the disease of obesity and type 2 diabetes, and also understanding. We just lost John. Understand what happened. I guess I'll come back. Also understanding about that, more about the fact that it is a disease, right? Trying to combat fat bias, trying to combat basically anything out there that's just completely awful. That's what we're trying to do. It's a big job. Let's put back John in. There you go. Hey, John. Okay.
Hey.
So, anyway, that's what I do here. I've been on a GLP medication for 2.5 years. I've lost 110 pounds. I've struggled with my obesity my entire life, as long as I can remember. My first memory of being on a diet, I was 8, standing over a rice cake in a kitchen, drizzling with chocolate sauce, trying to stay within my points and trying to learn how to control the size of my body, which I was never able to do. And honestly, even until now, and I am not in a small body now, 110 pounds later, but I am in a healthy body. And that is what it's about. So we can go over to my friend Kat. Kat, who are you? What's your from? What's up?
Hey, I'm Kat Carter. I am on also on the MJs, the Manjaros. I lost 70 pounds. I love fitness. I've always been fluffy fit. I was always in a larger body. And like Kim, I'm also still plus size, but I kind of like it.
I do
So,
too. Like,
but
yeah.
if I drop another 20, I'm not gonna like, kick it
Yeah,
out
I
of
won't be like,
bed.
oh
But
darn.
yeah.
Oh darn, I'm a
But
12.
I'm
Like
okay. Am I I said my doctor is okay with it too. So
yeah.
boom, boom, boom.
Boom boom. I love
And
it.
that's it.
I think being healthy and being able to move your body throughout the world is all we want. And
Right.
it's literally what everyone deserves. And we need to get a handle on all of this because obesity
Oh,
can
yeah.
literally, with all the things it leads to, bankrupt our country. And that's what we fight for here. So,
You're right.
John, tell us more about you. I
Well,
mean, Bear. I forgot you're Bear when you're on the podcast. Bear.
I'm Bear the Extraordinaire. I am
Huzzah.
the podcast editor, the
Yep.
person that makes it all happen. So make sure that you ladies look lovely and consistent across all platforms. I have been on the Mounjaro with Kim since basically the beginning.
Mhm.
I am almost at my goal weight. We actually weighed me a couple days ago. I am 286. So exactly 36 pounds away from my goal
Very
of
exciting.
250.
That's
So,
close.
yep, I
Very
am
exciting there.
I am very, very excited. It gave me a little bit of a,
Boost.
giddy in my step there for a little bit. I was, pretty excited
Giddy in your
about
step
that.
instead of a hitch in your giddy up.
A giddy in my hitch, a hitch in my giddy. I don't know, whatever. We can do some down on the phone stories in a little bit,
No, no down on the farm. We don't have time
Okay.
for
All right.
that. We're on a schedule.
Yep. That's a very important conversation to have today.
It
All
is.
right.
We're going to have Scott Brunner join us. He is the CEO of Alliance for Pharmacy Compounding. We got some news, and the reason this is coming out today, it's very timely. Yesterday, that they're ending the shortage, and so a lot of people in our community are fairly devastated. And the videos have gotten me to where I can't scroll for my mental health because the amount of people that are going to suffer and that are suffering and terrified
Yes.
needlessly keeps me up at night. So I'm going to try to focus on the things that I can, and this is what I can do. Okay.
Yep. This is what we can
So
do.
let's learn together, guys. Okay. All right, here we go. Welcome, Scott. We're so glad to have you.
Thank you. I'm delighted to be here, and congrats to you guys on this journey that you're on and the success that you're finding with these wonder drugs. They are wonder drugs.
They
There's
are.
no question about that.
No question.
Yep.
I mean, Scott, we went to, John and I went up to the Senate Health Committee. They had, where they had the CEO of Novo come in. And I was encouraged to hear our leaders speaking about obesity with as horrible as it is. And they did 100% call them miracle drugs.
Yeah.
You know what I mean? And it's not a miracle drug for weight loss. It's a miracle drug for people that have the disease, metabolic disorders that we haven't been able to ever treat before.
Oh,
And
absolutely. Yeah.
we're trying to change that,
Well, and the range of issues that these drugs
Yes.
are indicated for. I keep waiting for them to say it cures male pattern baldness. We haven't but it's still early, so you
It
never know.
wouldn't shock me if it does. I'm just saying. But
Right.
I think it's interesting. They approved, or they're trying to get it approved here. I think for the FDA for help with sleep apnea, which most of the time is caused by obstructive, right, in terms of the weight.
Mhm.
But in the UK, they were like, no, it's not necessary because we know that it's primarily to treat obesity and la la. And I thought to myself, well, it's great that they were trying to get approved over there, but the problem is primarily over here, right? Like in terms of the reason we have to get all these indications approved is because there aren't enough insurance companies that cover treatments for obesity as a disease, so that's why we have to do it here. So I just thought that was kind of interesting, stuff in the news. Anyway, so we did get some bad news yesterday, but I would love for us to talk through that today. If you could give us a little bit of a background on the Alliance for Pharmacy Compounding and kind of what you do in your role in your organization, just to get us started, I think that would really help.
Yeah, happy to. The Alliance for Pharmacy Compounding is the industry trade association for pharmacy compounding. Our members are pharmacists, of course, pharmacy technicians, but also educators and supply chain professionals, even some regulators and providers, prescribers in the space. We represent somewhere north of 600 small businesses And compounding is a small business industry. The big box pharmacies, the CVSs and Walgreens, generally don't do compounding. If they do compounding, it's just very basic, adding flavoring and that sort of thing. And so it's very much an independent business oriented industry. Pharmacies on Main Street that are doing some level of pharmacy compounding. Overall, we represent about 5,000 members, and we are the voice for compounding. So we've been quite involved in this 2-year period we're in where these FDA-approved wonder drugs have been in shortage. And as you may know, compounding pharmacies are authorized when a drug is currently in shortage to be able to make copies of the drug. And yesterday's news put an end to that, or the end is in sight for Tirzepatide, compounded Tirzepatide injectables that are copies of Mounjaro or Zepbound. Kim, we're not hearing
Kim, you're on mute.
Yep, on mute, babe.
Sorry, the dogs.
Right.
You said something on LinkedIn that I thought was really interesting. You said it's interesting how when we're talking about, GLP-1s, people call them knockoffs, right? Or the media calls them knockoffs. But if we're talking about what we're doing for cancer patients and other patients that are sick, nobody calls them knockoff.
Right. Well, it's been interesting to me how many reporters have seemed to think that compounding arose around GLP-1 drugs, when in fact, pharmacy compounding is the foundation of pharmacy practice. It's where pharmacy began, and it's something that's been authorized in federal law for years and years and years for a couple of reasons. So FDA-approved drugs in our healthcare system are the gold standard. The testing and the rigor with which those are produced is unmatched. And so if a prescriber judges that an FDA-approved drug is appropriate for a patient and is available to a patient, the FDA-approved drug is what should be prescribed and dispensed. Sure. But we've been in this extended period now, 2.5 years for the Novo Nordisk GLP-1 drugs, and right at 2 years for the Eli Lilly drugs, in which the drug has not been available. And so federal law allows compounding pharmacies to prepare copies of those drugs while they are in shortage. And one of the problems with our industry is that we are somewhat data poor. Compounded drugs are generally not covered by health insurance. And so there's no repository or registry to say we've got this much market share or we're filling this many prescriptions, because as I've indicated, these are independent businesses. And so there's no aggregation of that data. I would speculate, though, that over the past 2.5 years, compounders have helped literally millions of patients access this wonder drug at a time when the drug makers have not been able to provide the drug. Yesterday's news basically doubles down on the decision that FDA made on October 2nd, when they abruptly resolved the shortage of Tirzepatide injection, and the abruptness is part of the problem. On the day that they took that drug off the shortage list, traditional compounding pharmacies had to stop immediately filling prescriptions for compounded versions of the drugs. And so you've got hundreds of thousands, maybe millions of patients who are left holding a prescription for a compounded drug that is no good. They can't fill the prescription. And so they need to either be transitioned to the FDA-approved drug or some other therapy. Maybe there's a different GLP-1 or even compounded Semaglutide, which for some patients might be the right move. Well, they got to get into their doctor. The doctor's got to determine the right prescription, has to write the prescription. If by some miracle it might be covered by insurance, and we do know there are certain indications where those are covered, you're probably going to have to wait a bit for a prior authorization from the insurance company. It might be 3 hours, it might be 3 weeks. And then they pop down to the compounding pharmacy with or to the pharmacy with their prescription, only to find that the pharmacy cannot acquire the drug from the wholesaler. And so that's where we were left on. FDA made the decision on October 2nd. On October 3rd, you've suddenly got these hundreds of thousands, maybe millions of patients who are frantic because they may be facing an interruption of a therapy that has been life-changing for them.
Yeah.
And so I think you probably know this story, but one of our sister industry organizations immediately filed suit against FDA, said that they were cavalier in ending the shortages they did.
Yes.
They relied on incomplete data from Eli Lilly, and alleged that the agency should go through a formal rulemaking process to end the drug shortage. Well, FDA was apparently so shaken up by that within days, within the same week that the lawsuit was filed, FDA goes to the court and says, hey, court, please remand this back to us. We want to reconsider. This is before the court has even taken any action on the lawsuit. So pretty, it's unusual that FDA would have taken this step. So they were given a 60-day period. They could reconsider. They went back to the court at the end of 60 days and said, we need 30 more days. Yesterday was the end of that 30 days. And what we saw, and this is important because I think some in the news media have confused it. The court did not act. FDA has not gone to the court. FDA released a letter it wrote to Eli Lilly saying that it was doubling down on its prior decision. Now, the one good thing that we find in that letter is that they listened to us. We had asked for at least a 60-day off ramp, so that there was time where patients taking the compounded version of the drug can at least get another refill while they're trying to get into their prescriber and get a new prescription for the FDA approved drug and all that. And so thankfully FDA listened and did that. They're allowing a 60-day tail or off ramp for traditional compounding pharmacies and 90 days for drugs that come from outsourcing facilities. We can talk about the difference in those if you care. Anyway, that's where we are. And I know I'm talking a lot, but
no, that's the goal.
You're already answering my question. So just go on, right?
Part of my concern about all this is that FDA's letter to Lilly says they certainly relied on data from the drug maker, and that's what federal law requires them to do. So can't slight them there. They say they've looked at data that we and other organizations provided them, and basically aren't persuaded that the drug maker cannot meet the need. And so they are saying, there are going to be some patients that may be inconvenienced like this, but by this, and they seem to say that rather glibly in my opinion, but that Eli Lilly can meet the demand. From what I'm hearing from pharmacies, the pharmacists we work with, when they go to their wholesaler portal and try to order these FDA approved versions of the drugs for their patients, they're coming up with big zeros, or they can only get like 3 boxes or 5 boxes. It's on allocation, and they've got a waiting list that has dozens. Some pharmacies have waiting lists that have hundreds of patients on them. So I'm just not persuaded that the shortage is truly over. And I think we're going to see patients who are going to be inconvenienced by this and who may have some interruption of therapy, and there could be health consequences because of it. So it's a real concern.
Yeah, absolutely. I think that what people don't understand is like when you're on this medicine and then, so we've been doing this a long time and we've been through all the shortages, like, cause we've taken all of them because of the shortage. When you're off it, if you're off it for a certain amount of time because you can't even find your dose, you're either going to have to increase because that's the one you can find, or you're going to have to decrease. And it's not like, oh, my weight loss is stalled. No, your inflammation returns, your pain returns. Like obesity is a vicious disease. And this is for whether it's the obesity version, right, or the type 2 version, both of them. We are taking them because we are sick people. You know what I'm saying? And like that narrative is lost. That narrative is lost. And it drives me crazy that even the FDA doesn't understand that you guys were the ones that approved it for the chronic weight management, which is treating obesity, right? It's a disease. So that's the problem. And then also if you get off of it for a certain amount of time, 30 days or so, it's out of your system and you got to start all over again. And that is a lot to have to titrate up and all of that to your body. It's a lot to deal with. It does hurt us. And it's those people who have, issues with blood sugar, pre-diabetic, diabetic. it messes with that, because a lot of us have to be at a certain level before our A1C is controlled, right? So not to mention like having to deal with the side effects when you get off of it and then get back on it again. It's not good for us. It's not. And I think that we're also perhaps like the FDA is looking at, okay, well, what about the patients that are on it now? Hey, there's like 25,000 scripts when Zepbound came out to begin with. It was being written a week. There's no way they can fill that. You know what I'm saying? And I think it's great that we have the option for the single dose vials, but ultimately that's still what, $500 a month, and it's 2.5 and 5, and that's it. We don't have the higher doses. So all the people that get started because their insurance won't cover it and they're on the brand, what are they going to do when they need to text it up and they can't afford it anymore?
That's the other piece of this that I'm concerned about. So let me start by clearly stating that the price of a compounded drug under FDA guidance is not a legitimate reason to prescribe a compounded drug. Compounded drugs are based on appropriateness or the inavailability of the FDA approved drug. But that patient that's hopping down to their prescriber to get a prescription for the FDA approved drug is almost certainly going to experience sticker shock. Because the reality right now is that the price of the compounded version of the drug is less than the price of the FDA approved drug. And so some of those patients are going to look at that sticker and they're going to say, I can't afford that. And then they will drop off the therapy. And all of those consequences that you've just enumerated are likely to play out. So we're worried about people who are going to be knocked off the therapy simply because of the price of the FDA approved.
Yeah, which is going to be, and I will tell you, as someone that represents, we try to the community, it's going to be millions of people. And we know in terms of, but that points to more issues, right? With the issues with access, affordabilities, PBMs, and all of that, which we would love to talk with you about if you're open to it later. We'll go ahead and move on to the other questions though, because I tend to go a little bit. Kat, I know we answered some of
we answered one, but there's, so is this like a hard, it's like a hard line in the sand that the FDA did, because I see 2025 coming in. We're at the end of the year. What if there is, what if there's got to be another shortage looming? Is this FDA decision reversible per se? Or is it going to be a back and forth?
Yeah, so FDA has the ability to place a drug in shortage whenever it determines that the supply of the drug is not sufficient to meet current demand. It's not a perfect system, but it is authorized in federal law, and so FDA makes that decision when a drug comes on and when it should come out of shortage. One of our concerns about what FDA has done here is that it may be underestimating the number of patients who are on the compounded version of the drug, and all of those folks now coming into the demand for the FDA approved drug could in fact knock Tirzepatide right back into shortage. I also happen to think, and I hope I don't sound like a nutty conspiracy theorist, but I think it is not unreasonable to speculate that the agency is doubling down on this because they're coming to the end of one presidential administration and the incoming of a new administration that may take a different view about GLP-1s than the current administration does. And so they're ending the shortage while they think they can because they don't think the new administration will. Now, again, that's pure speculation, but it's not unreasonable speculation.
Gotcha.
So you still got semaglutide out there. It is in shortage. We saw yesterday that Novo Nordisk had written to the government of whatever the health agency in Australia is, indicating that they saw prolonged shortage of semaglutide. Now we're seeing here in the U.S. announcements that the various dosage forms of Novo's product are, quote, available. But I want to be clear, availability doesn't mean that a drug is not in shortage. Availability is great, but the determination is from FDA. When FDA believes that the supply of the drug is sufficient to meet demand, it'll take the drug off of shortage. So 2025 is going to be interesting. It's going to be interesting because we're ending the year with this shortage on Tirzepatide. I'm eager to see how that transition goes, and we're urging our members, have been for several weeks, to be transitioning those patients.
Mhm.
Even if the patient gets the script for Mounjaro or Zepbound and goes down to the pharmacy and can't get it filled, at least they've got a prescription for whatever point in time the drug, the FDA approved drug, is available.
Yeah.
Yeah.
For semaglutide, we may see an end to the shortage in 2025. It may go on, but I do not foresee that that drug is available in any quantity to meet the demand.
The only thing that, I agree. The only thing I was thinking is that, so basically we know that they're saying it's all available and they don't want it on the shortage list anymore, but you're saying FDA has not said that it is not in shortage, correct? Semaglutide?
Right, on semaglutide. So the way, if you go to the FDA drug shortage page and you type in semaglutide, it's going to pop up and say currently in shortage. And that is the designation. Now, if you click through, and the FDA shortage list is dang confusing, but if you click through, you're going to see that some of those dosage forms are actually showing as available. And available is great, but available doesn't mean that FDA has judged that the supply is sufficient to meet the demand.
Okay.
Currently in shortage. When it changes, when currently in shortage is changed to resolved, that means the drug is no longer in shortage, and compounding pharmacies cannot prepare copies of those FDA-approved versions.
Yeah. Yeah.
So, Scott, speaking about that, the compound pharmacies and kind of the copies of the medications and everything that the compound pharmacies are able to make, we've heard comments from Eli Lilly, Novo Nordisk, in regards to these medications, and they make an assertion that they're not easy to replicate, that there's some secret special sauce, I guess, that makes it hard for the compound pharmacies to make it. What do you think about that? Is it true that it's a hard thing to copy, or is it more of a, we have a patent on this and we don't want you guys touching it because you're affecting our money type comment?
Where to start? Okay, so federal law requires that FDA keep a list of drugs that it determines are demonstrably difficult to compound. And that's a mouthful, really hard to say. So we call it the DDC list. The interesting thing is that they have been charged with creating that list for years, and only in the past 12 months have proposed a rule that contains the criteria for what sorts of drug products would go on the list. The fact is, right now, there's no DDC list. And so it's interesting that both Novo and Lilly have gone to FDA to urge them to add semaglutide and tirzepatide to the DDC list when there's not really a list because the criteria hasn't been finalized. So that's interesting. Set it aside. This whole argument that the drug makers are making that tirzepatide and semaglutide injectables are demonstrably difficult to compound is complete and total nonsense. And it is posturing and it is positioning. It's interesting to me that it took the drug makers 2 years and 2.5 years into this shortage to suddenly determine that the molecule was difficult to compound and FDA ought to prohibit it. That sounds a little fishy to me. I believe that they may be confusing the fact that these the active pharmaceutical ingredient is indeed demonstrably difficult to manufacture. But that's not what compounding pharmacies are doing. Compounding pharmacies are taking the API that's been manufactured, that they are acquiring from FDA-registered facilities that comes with a certificate of analysis, and they are creating a compounded injectable from it. The pharmacists that I talk to say there are many compounded drugs that are considerably more difficult to compound than semaglutide and tirzepatide. And yet nobody's making an argument that those should be added to these other drugs should be added to the demonstrably difficult list. So I am not persuaded by the arguments. I have to say, Eli Lilly's letter is so heavily redacted. The request that they made to FDA is so heavily redacted that you can't really tell much about what they're saying, about what their arguments are. The Novo letter is less redacted. One of the interesting, I find it sort of humorous, one of the interesting things Novo argues is that recombinant peptides, and that's what its semaglutide product is. And I'm not a chemist, so this is going to be a really, really layman's version, but a recombinant peptide is created in organic matter. Novo is making the argument that because the semaglutide that compounders are using is synthetic, it's a synthetic peptide, synthetic semaglutide, that it is somehow, that Novo's is somehow superior to that. Well, never mind that FDA in its new drug approval process has long said that it considers recombinant and synthetic peptides as, quote, the same. It's funny because Eli Lilly's drug is a synthetic peptide.
Yeah.
Tirzepatide is a synthetic peptide. And so they're arguing both against compounders doing this and their competition. Anyway, it's a bunch of hogwash. Now, that doesn't mean, sorry, I'm from Alabama. Forgive my.
Roll Tide.
Oh, shut your mouth.
Not kidding.
I live in Auburn, Alabama. Surely you just didn't say Roll Tide.
Oh, I'm so sorry. Listen, Auburn is so hard to get into, okay?
I am going to have to be careful about what podcast invitations I accept.
My LinkedIn profile.
I did not vet you folks the way I should have.
Oh, SEC drama.
Mr. War Eagle.
Yes, War Eagle. We have a daughter that went to UGA though. She's the
Really?
She's the black sheep.
Go Dogs.
I'm the black sheep of mine.
Right. Anyway, it's just a load of nonsense. Yeah. But that does not mean that FDA won't take it seriously. And so it may be that FDA will consider the arguments and move to put it on this DDC list that doesn't yet exist. I hope that's unlikely, but could happen.
It sounded like I remember they were trying to kind of Eli Lilly was trying to figure out a way to like do that with a called Replication coming out, like making it so it possibly could never be compounded, you know? And you know, I it's such bullshit. It's just like you said, like sorry, it just is what it is. They did this way too late in the game. You know what I mean? Like clearly they're just like, grasping at straws. They're pretending like, oh, like our business isn't hurting. No, you're not hurting because you do sell everything you make, right? But you don't sell everything that you could because you can't get it to market. And that just is what it is. Like, and I think very highly of these, of what they've been able to accomplish and create to change our lives. But, you know, at the end of the day, if you can't find a way to make it affordable, and all the research we've been doing for the podcast into how other countries are handling, you know, getting this to market, how other countries are being charged for this. You know, in the UK, they get it through like, they don't even go through like their system. Like everybody acts like they do. And they've all got it figured out and they negotiate prices and stuff. No, the price is the price in the UK. And it's $150 about US for Mounjaro, for a single use pen for Mounjaro from a regulated pharmacy directly from Eli Lilly. And that's what it is. But here, $1,100 a month. You know what I mean?
Yeah. Absolutely.
So it's like, it's a bunch of garbage. Like the whole system is so messed up. Well, and they take advantage of it. Like they know what the market will bear. And that's why it costs what it costs.
Well, and the interesting thing about this is that the drug makers have responded. And the request, John, on the DDC list to prohibit the compounding of these is only a very small part of the shenanigans that the drug makers have pulled. I mean, we're talking cease and desist letters to pharmacies and to prescribers. We're talking about letters that they are sending to patients saying, oh, we understand you've been prescribed a compounded version of Tirzepatide. We would like you to release your medical records to us. They have absolutely done that. And so threats and legal action and all of this, which makes me think that they are mistakenly viewing compounding as competition. I would argue strongly that we are not competing with them. Again, remember what I said earlier. Compounding is only when a prescriber judges that there's no appropriate FDA-approved drug and prescribes a compounded drug, or when the appropriate FDA-approved drug is not available. That's not competition. We're filling a gap where a commercially available drug does not exist.
Now, you're talking
So-
specifically too about like direct copies, or we've kind of like talked about that.
Yeah,
There
yeah.
are people that still think that if you are able to get compounded medication, or let's just say like Tirzepatide with B12 or B6, that's a way to get around things. Have you heard much about that, or what is your take on that?
Want the fastest working GLP-1? For half the price, Ro now offers FDA-approved weight loss injections cheaper, with results you can see faster. Lose 15% of your weight with the formula from Eli Lilly that hits not one, but 2 hormones to curb hunger and nausea. Weight loss faster, confidence higher, price cheaper. See if you qualify at ro.co/TV.
Yeah, there are a couple things going on. One of which is absolutely legal and appropriate, and one which scares me to death. Let me start with the one that scares me to death.
Let's do it.
Even with the October 2nd, that abrupt end of the Tirzepatide shortage by FDA, we began immediately to see a huge uptick in traffic to Reddit and TikTok forums, chat rooms, et cetera, where people were looking to acquire the powder version of the drug and were mixing it in distilled water with the intention, and I know some of them actually did this, of injecting themselves.
Yes.
That is remarkably dangerous. And
Yes.
I do have some sympathy for the desperation that some
Yes.
people feel with the end of this, but those folks are taking their lives into their
Yes.
own hands.
Yes.
They do not. I do not think they thought about the potential for contamination in trying to inject themselves. I
Yes.
think they may not be thinking about the fact that the substances that are being shipped to them from China and India and wherever may not be what they purport to be. And
Yes.
Right.
so all of this conversation about end of shortage is bumping up interest of some folks to go on what I would call black market, but
Yes.
to these illicit sellers of substances.
Yes.
Tirzepatide, Semaglutide are FDA approved drugs. They are prescription drugs. You should not be able to get them without a prescription. And if
Yes.
someone's willing to sell you one of those without a prescription, you can bet it is not a legitimate compounding pharmacy. So
Yeah,
that's the
absolutely.
one that scares me.
Yeah.
Remember, I talked about appropriateness is a
Yes.
reason for a prescriber to prescribe a compounded drug.
Mhm.
We know of many instances right now when the prescriber is looking at the side effects from Tirzepatide or Semaglutide and is determining that they're going to add B6 or B12 or some other substance to the drug to make it a combination drug to help alleviate nausea and some of the other
Exhaustion.
side effects. Well, that's a case of a prescriber looking out and saying, what I want for this particular patient is not commercially available, and I am going to prescribe a compounded drug to meet the patient need.
Right.
That's what compounding is about. Now, I am somewhat concerned that we are seeing some entities enter the space, mostly new in the compounding space, a lot of them telehealth platforms, and there are some great telehealth platforms.
Sure.
By the way, I'm not talking about those.
Yeah,
But
absolutely.
but that seem to be viewing the ability to create and mass prescribe a dosage form or dosage strength or drug combination that is not commercially available as a line of business for them and a way to skirt the requirement of using an FDA approved drug. And I believe that's bad for compounding. I believe it in some ways is sort of poking the bear of big pharma. And I talked about price earlier. It injects compounding in the price debate in Congress. And I could see drug makers responding by going to Congress with a proposal that could get some uptake that would cut the legs from under compounding in general. And when I say that, I'm not no offense, but I'm not as worried about the patients that are taking GLP-1 drugs as I am about the millions of patients who are taking a range of compounded therapies for which there is no FDA approved corollary. And if you knock the legs out from under them, they don't have anywhere to go.
Yeah, absolutely.
Yeah.
Yeah, it's a massive, I mean, it's a massive issue. And I think that there are some people that are saying, oh, you can do that. And then there are some people saying, well, but you can get your own B12 and your own B6 without being compounded within the medication.
Well, and that's
Right,
the question. But
Yeah.
but when you look, so compounders are guided in this situation by a document that we call the essentially a copy guidance, because that's part of the name. It's from FDA, and it's the essentially a copy guidance. Well, that guidance document describes scenarios in which combination drugs are appropriate, in which they might not be appropriate. But FDA says clearly that they will not question the medical judgment of a prescriber.
Yeah.
And so I do not think that FDA is going to swoop into these prescribers. In fact, I don't think they're going to pay attention to the prescriber. I don't think they're going to be citing pharmacies for making combination products because, like you said, well, you could take a B12 injectable and a Tirzepatide injectable separately and achieve the same therapeutic result. Now, what it's going to be is lawsuits from the drug makers themselves that will be based on their intellectual property rights. It's not going to be about whether, does that drug really make a clinical that combination make a clinical difference? It's going to be, hey, that's our drug, that's our patent, you can't use it. And I'm eager to see how that plays out.
Because there are some telehealth specifically and some companies specifically that have doubled down and said, that's what we're going to do. And they're willing, I guess, to deal, like you said, like in terms of not necessarily FDA issues, right? But do I want to deal with Eli Lilly and their machine of legal, right? Because that's what it is.
I would presume those entities have looked at the economic model. They believe there's a potential to serve patients and turn a profit doing that and manage the legal risk involved in that.
Yeah, I think you're right. It's like it's just going to depend on how they want to handle it. Yeah.
Well, speaking of risks, just real quick, I had one additional thing I wanted to ask you about. What type of frustrations and like roadblocks do you, like your organization and just pharmacies in general, run into when dealing with the FDA? Like I know a little bit from working, for pharmacy support, for prescription software. I know a little bit of stuff that can be ran into with the audits and stuff, but like on a day-to-day, or like when it comes to these things, like what type of frustrations and blocks are you guys coming across, and how are you getting past them or working around them?
Yeah, well, it may be odd. You may think it odd for me to say this, but we have a good relationship with FDA. I believe these are hardworking people of integrity that are looking to protect the health of Americans, and that is their mandate. I also think they have some built-in biases that they can't seem to get around, and that concerns me. We have an FDA that has at times in recent years acted with obvious bias instead of basing the decisions that they're making and promulgating policy on the science. And so that's a concern. Again, I still think they're people of integrity. I think sometimes they don't see that they're biases. I also think we have an FDA, and I could argue both sides of what I'm about to say. We have an FDA that says that any substance that is not proven safe is therefore unsafe. And I think that mindset makes them reject experimental therapies. And I know we're talking about GLP right now. Let's talk about ketamine. Let's talk about ketamine nasal sprays that are changing the lives of soldiers that have come back from overseas with PTSD. FDA don't like that. And yet those patients are living much richer lives because of those compounded nasal sprays that they're taking. Sorry, a little off the subject, but
no, that's actually super interesting.
That's one
not
of
that off the subject, really. We're really trying to blow up healthcare in general. So.
One of the areas where FDA has blinders on, and I would love to see them more interested in the possibilities. Again, I'm not asking to act capriciously or to put Americans' health at risk, but I think they are overcautious in a lot of what they do. And so that's a real frustration related to GLP-1s. Every time FDA issues a statement about compounding, they have to go through the litany of all the dangers of compounding.
Sure.
And the result is often for media to pick up the dangers and not really what FDA is saying. So, for instance, a few months ago, we had a warning from, wasn't a warning, it was an alert, I guess, from FDA about dosing errors with compounded versions of semaglutide and tirzepatide. And they focused it on prescribing errors where doctors were getting the titration wrong, or patients who were using the vial and syringe system that is mostly what compounders are using. I mean, Novo and Lilly do have that wonderful pen, patented pen that they use. That's generally not what compounders are using. And so patients are making errors, injecting too much, too little, et cetera. And so FDA issued an alert saying, be aware of this. And it is something to be aware of. They did not say that the compounded drugs that were being injected by a vial and syringe system were inherently dangerous and oh, beware. But that's the way it was taken in the media, and that's how much of the reporting went. You know, vial and syringe systems have been used in this country for 75 years. Anybody who has diabetes, who is of a certain age, knows the vial and syringe system. So it is no more dangerous or risky when injecting GLP-1 drugs than it is in injecting insulin or anything else you have to do.
Absolutely.
But people's heads flew off their bodies and flew around the room talking about, oh, how awful this is with the vial and syringe system that compounders use for GLP-1s. Again, nonsense. And FDA was right to point out the concern, but the way they portrayed it in their announcements, it was what really turned out to scare a bunch of people.
Yeah, absolutely. And that does nothing but like perpetuate the stigma and the bias for all of us that are trying to treat our disease, right? And the amount of people that say you don't have an Ozempic deficit and all of this kind of like nobody's saying that, right? We're saying like this is an actual treatment for a disease, right? And it just continues. And those people who don't want this for whatever reason, it's usually about them, right? For us that are struggling, because it challenges everything. I think that's also what people think about, but these medicines specifically. It challenges how our society operates in terms of how we see those with obesity, how we see those that are fit and thin, right? And even how companies hire, how companies choose benefits. It's challenging everything. Because if all of a sudden the people that are fat, that are known to be like fat and lazy, are getting thin, what does that mean for the people that are thin? Are they now, of less moral worth, right, than they were before? And I think that's where a lot of this rub comes from. And anytime that kind of stuff gets out there, it just breaks everything we've been trying to change. You know what I mean? So
I wonder. I have this theory, and you can either validate it or tell me I'm crazy. You mentioned my comment on LinkedIn about how nobody's calling them knockoffs when compounders are making cancer drugs during shortage. Nobody was calling compounded drugs knockoffs last fall when amoxicillin suspension and acetaminophen suspension for a pediatric for children was in severe shortage, and compounding pharmacies across the country stepped in to fill that gap. And yet, when we talk about GLP-1s, I can't. Bloomberg's calling them knockoffs. Yesterday, the Washington Post called it a knockoff, and I'm wondering if it's not some sign of reporter bias because they view these drugs, because the drugs are for weight loss and they don't perceive weight loss as a serious issue. Now, again, I'm speaking very speculatively, but it sort of reeks to me of that sort of bias. Yeah,
maybe just like not enough research either. Some people just start to repeat what they hear over and over again.
Sure.
Well, I've said before, these aren't handbags on some New York sidewalk. They're not knockoffs.
Absolutely not.
They're made in sterile compounding labs under USP standards and state law and federal law. It just baffles me.
And
it's not fair.
No, it's not. And I do think that the issue with people, we know that there are doctors out there that don't understand the titration, that don't understand that everybody's body is different, that don't necessarily understand the disease of obesity and insulin resistance, the underlying dysfunction, all of those things, which is why we do hear people sometimes, because of the shortage, come in and say, well, my doctor gave me 2.4 of wegovy to start, which is insanity. Like, and then they get sick and they in the hospital and it gives all of this a bad name, right? And they run with it. In terms of what you're saying, in terms of like the media and stuff, just the fact that we're even calling them weight loss medications pisses me off. And it's literally like what makes me so passionate and why I do this and make this content. It's not chronic weight management. It's the chronic piece, chronic, right? It's because with most of us, 93% of us, we have insulin resistance, right? We're on our way to becoming diabetics. The reason a diabetic medication is working for someone that has obesity is because primarily of insulin resistance. People don't understand the body doesn't work right. And we have to put like, I would say like a spoke, like in a wheel to stop it so that we can all start to function in the way that it should. We can process insulin efficiently. Yes, we eat less. Yes, we move more. Yes, losing weight is a part of it. But the inflammation control, the mind changes, the being able to put your brain in a state, right, where you can all of a sudden make better choices that you could never make before because the food noise was so loud. I mean, people don't get it. They just think because of the way society is that if you are obese, you are fat, you are lazy, you are not moving, you are not eating well, you are not trying. And that's how it is. So people who do have, and I hate to call it thin privilege, but it kind of is, right? Have this, they don't even consider it. But nobody stops to think, why do you think that we would take the most expensive medication that there is, that's in shortage, that you're constantly criticized for, right? If it was just about eating less, if it was just an appetite suppression, that's insanity. And it's because the media continues to call them weight loss medications. And we all have to stop. Like people in our community do the same thing, but it's because that's what people know. And they're hooking them in that way. And I'm a product marketer, right? They're hooking them that way. They're bringing them in and trying to educate them through. But ultimately, this is for diseases, And when you're talking about like this issue too, instead of they're confusing, right? FDA, they're confusing 503A, 503B pharmacies, company pharmacies with black market, with peptide companies, with people who are buying it off the internet. And I am telling you right now, it sounds awful, but people out there who can't get it from a safe place, they will immediately go to the place they can spend $100, right? And get what they think is Tirzepatide, what people are telling them is retatrutide. That's a whole nother thing. There's a whole nother market for that. Let me sell you retatrutide without a prescription, without care. This medication, you need care. You need the care of a doctor. You need it. It's people don't understand. And what they do because they don't have it is they come to TikTok. Well, guess what? TikTok's going to probably be gone soon. Yeah. There's just a lot of people banning things these days,
Here's what I would say about that. I mean, there's a ton, and you guys know this. There's a ton of you can find all manner of dosing advice for GLP-1s on TikTok.
Yes,
I'm here to tell you, TikTok ain't the place to go to learn how to inject your GLP-1 injectable.
Yes.
Talk to the freaking pharmacist.
Yes,
pharmacists know this stuff, and even if you use a telehealth platform, if that telehealth platform is doing fulfillment, the pharmacy that's fulfilling the drug is a 503A pharmacy, you can call the pharmacy and ask questions. It's what they do. And patients should understand they shouldn't just have to worry about this or wonder or look it up on the internet. Call the pharmacist.
Absolutely.
Yep.
Yeah, you have to. And that's one of our things our podcast does, right? Is we're trying to give everything to the people that they need to advocate for their health, because the reason, unfortunately, like that our community on TikTok or on Instagram or whatever exists is because the gap in all of these areas is so vast that people don't even want to talk to the doctor, not to mention doctors for the majority of our lives, and we've had obesity, have blamed us for the obesity. They just have, and because of that, there is a mistrust, right? To even want to go there, they'd rather go. But the problem is there are people on TikTok who are giving medical advice, right? And that is not okay. It's one thing to say, this is my friend, this is what they did, this worked for me, go talk to your doctor and ask them about this. So that's what we try to do here, right? Is provide the information and say, this is the question for the pharmacist. This is the question for your doctor. If you do what I do, there's a very good chance it's not going to go great, right? And there are people who for example, they're in maintenance and they take their medicine every 2 weeks, right? You do not need to be listening to what other people are doing with their maintenance. It's great to have information and data, but that data and that information should always go back to a provider, to a pharmacist, to experts, not Kim from the Plus SideZ, not people on, it's not.
And I would say this about, I represent 5,000 of these folks.
Yeah.
Pharmacists love answering these questions. They are chemistry and science geeks. I'm sorry, I love them to death. But they're not going to turn you away when you ask that question. I mean, you may ask them what time it is, and they tell you how to make the watch. But they know this stuff. They are the experts.
Yeah.
Yeah. I did find in the beginning when these medicines were a couple of years ago when they were first coming out, I do not feel that the pharmacists, the regular pharmacists like at CVS and Walgreens and stuff, had any idea. Like I really don't think they did. And but I have seen the push to where they have to, and I've seen it change. Right. And then I hear when I go, do you have any questions for the pharmacist? Right. Which I think is great for all pharmacies to be able to do that. But I do think the idea that people should call their compound pharmacy and ask them these questions, it's a really good idea.
Well, one thing we reminded our members in the wake of FDA issuing that alert about dosing errors and prescribing errors related to GLP-1s. You mentioned they always say, do you have any questions? And I always say no. You probably always say no as well. Yeah. We're telling pharmacists, don't let the patient say no. Hold them if you have to, and talk to them about this drug that you're dispensing to them so that they don't get it wrong.
Yeah, because people do. And that's the thing is, even when you tell someone, hey, 0.25 of Ozempic, wegovy, right, is the starting dose or whatever, and they take it. There are some people that have very big reactions to 0.25, and then it's a spectrum, right? And insulin resistance is a spectrum, and we talk about that on the show. And then we have the same issue, right, when it comes to any of the medicines, is your body is just going to respond differently. So at that point, it's not, let me go to TikTok and ask people, right? If you can still do that, you can still have community and ask those questions, but that should always be taken back to an expert, right? You shouldn't be making those decisions on your own. You shouldn't be, I'm just going to try to do this every other week. And it's not because I'm judging you, because I am you, right? I'm talking to more people right now. I am you. The thing is that you deserve care. Like, I know that with everything that's happened to us, we forget that, but we are worthy of care. We deserve care, and it is available. And if you ever have a hard time with it not being available, I know everybody, and I will make sure that you find a place where you feel safe. And I just want everybody to understand that, because you are deserving. And there's so much unworthiness in people that have struggled with obesity because the trauma is vast, So I just want everybody to hear me in this moment. Okay. All right. Anyway, John, did you get your questions in, Kat? I think we're getting at time for you. How are you doing on time, Scott? Can you give us 10 more minutes?
Oh, yeah, sure.
Okay, great. Just to make sure.
Well, we did cover a lot, but I did have the kind of a little deeper question for you is the safety concerns with compounding, citing issues with dosing errors that we just spoke about. How does the Alliance address some of those concerns while they advocate for access to compounded medications? Is there something in place?
Yeah, we do that in a variety of ways. I said earlier, FDA-approved drugs are the gold standard. Compounded drugs are secondary therapies that should always come behind FDA-approved drugs.
Sure.
Compounded drugs are not FDA-approved. Drug makers would suggest to you that because they're not FDA-approved, they are therefore inherently unsafe. Well, again, more nonsense, and that's sort of a logical leap.
Right.
Compounding is authorized in the Food, Drug, and Cosmetic Act to fill gaps in the supply chain like this. And so the compliance, the safety framework in which compounded drugs must be prepared is remarkably rigorous, particularly when you're talking about sterile compounded drugs, which is what injectables are. So first of all, make sure you're using a state licensed pharmacy, as opposed to some entity you've never heard of online. If you're using a state licensed pharmacy, you know that pharmacy is inspected regularly, that it must adhere to state and federal law, that it must be compliant with the standards, the compounding standards of the U.S. Pharmacopoeia. They are national standards that are designed with the intention of producing drugs that patients can take safely, safe, quality drugs. And so if you go in a pharmacy and you've got questions, ask to see their last inspection report. If you're wondering if the compounded drug really is what it says it is, ask to see their third-party testing. Now, again, these are dense documents. They're geeky. They're chemistry, but it's pretty compelling. It's a shame that you have to go into a compounding pharmacy and do it, because you don't. When you go into CVS to get your lisinopril or your amitriptyline, whatever it is, you're not asking those questions. But compounding pharmacies can demonstrate that they adhere to the regulatory framework that is in place, and that framework is a good and strong one. I will say, compounding pharmacies that skirt the rules cannot stay in business very long, particularly if they're making patients sick. And I don't know of any indication that's been happening, but they just can't. The Board of Pharmacy will swoop in and shut them down. Right. So that's just being cavalier about those things is just not a good business strategy.
Yeah. Gotcha. So for our people, things that they should look for, right? So one, if you don't feel comfortable, like ask these things, whether it's dosing or whether it's, are you a state licensed compound pharmacy? Where would that information be? Like, do we need to make sure they have a website? Like, is that the kind of thing that our people should be looking for?
Yeah, well, in terms of determining if the place you're getting your drug is a state licensed pharmacy, we have a tool on our website. Sorry for the promotion here.
No, we like this. We'll put it in the show notes.
Well, it's called Is It Legit? And so it's just a shortcut for looking up a board of pharmacy on a state board of pharmacy website. Okay. The state board websites are dense, and you may have to go through 12 clicks just to find the licensee lookup. Right. So we've taken all the work out of it. Okay. If you go to pc.org, a4pc.org/isitlegit, you can find that tool. And I'm in Alabama. You can click on Alabama and it'll take you right to the licensee lookup in Alabama. Okay. If a pharmacy is not listed there, it means it's not licensed in that state. And it may mean that it's not licensed at all. Just make sure when you enter information in the Is It Legit, you got to get the pharmacy name right, because if you get the pharmacy name wrong and they're not listed, So anyway, that's a good thing to do. You also, particularly when you order from when you're prescribed a compounded drug via a telehealth platform, when the drug comes to you, you may use Bob's telehealth platform, but the drug ought to have a label indicating the pharmacy that is dispensing it. And so that's one way you can, and then once you see that label, you can look up and say, I've never heard of this pharmacy. I'm going to look it up and make sure it's a legitimate pharmacy. So you can do that as well.
If you see something that says that it's for research purposes only, or something that says,
skip it.
Skip it. Compounding pharmacy, legitimate compounding pharmacies will not be using research grade product. But it is not allowed under federal law, under state law. There are a lot of sellers out there of that crap right now, and beware of it. FDA just last week issued warning letters about 4 sellers of research grade reported Semaglutide and Tirzepatide, and we're cheering them on.
Absolutely.
Those folks ought to be run out of whatever business they think they're in.
Oh yeah. I don't even know how they get away with it. And I think anything that says retatrutide, like, guys, don't do that. Like, it's still in long-term studies. There are people
there is a clinical trial. There still are clinical trials
going on right now, guys, that don't get approved. It does happen.
But retatrutide doesn't meet any of the current criteria for compounding in the first place. So if a pharmacy is saying they'll make that for you, they are in violation of federal law.
Okay.
Okay, that's good to know.
We have to know what we're putting in our bodies. I know we get desperate, but we have to know.
Yeah. Just so you'll know, there are a lot of substances out there that can't be compounded. Food, Drug, and Cosmetic Act provides a 3-point criteria. In order for a compounding pharmacy to use the active pharmaceutical ingredient, it either has to be a component of an existing FDA-approved drug, Semaglutide, Tirzepatide, both meet that requirement, or it has to have a monograph from the U.S. Pharmacopeia, or it's got to be on the special list FDA keeps, and there aren't a lot of things on that list. And so retatrutide right now doesn't meet any of that criteria. Compounders can't touch it.
Yeah. Everybody hear that? Good. I just want to make
Mhm.
sure. Good. If
For the sake of
they're
your
giving it
safety.
to you,
Yep.
it's sketchy, it's not legal. So don't do it.
Yeah.
Okay.
One of the things you asked, Kat, earlier
Mhm.
was how we coach our members about this. If you
Mm.
go to that same website, a4pc.org, we've got a
Okay.
section there of best practices. Now, again, these are best practices for pharmacies and pharmacists,
Okay.
but it will demonstrate to you some of the compliance rigor and the things pharmacists have to do to make
Yeah.
sure they're compliant with federal and state law. There's one on compounding shortage drugs, which includes Tirzepatide and Semaglutide. There's
Yeah.
one on marketing claims that can and cannot be made about compounded drugs. We've got some on ketamine, some other things on there.
Okay.
But, that's one way that we try to coach our members and guide our members about all the steps they should take to
Great.
make sure they're keeping patients safe.
Okay. I like it. I think we want to talk a little bit about looking ahead, right? So as the FDA monitors the semaglutide shortages and the pharmaceutical companies expand manufacturing, right? Because we know specifically that Novo just bought a company to help do that, right? To be able to
Mhm.
expand. What
Yeah.
role do you see compound pharmacies playing in the future of obesity and also for diabetes care? Because as my understanding, some people have said don't use compound if you have diabetes. So can you give us some insight there?
Yeah, I hadn't heard of that last one.
I know.
Well, first of all, our members knew that there was a shelf life on their ability to compound copies of these
Mhm.
FDA-approved GLP-1 drugs. And with Tirzepatide, it looks like we're at
Yeah.
that beyond use state on that, at least within the next 60 or 90 days. I think looking ahead, it's going to be interesting to see if this shortage is truly over, or are we going to see the drug knocked right back into shortage as the
Right.
demand grows, as we try to transition these patients taking compounded Tirzepatide
Yeah.
over. Who knows what's going on with semaglutide? You hear the company say one thing to American audiences, but it is telling other countries that they're still in shortage. I mentioned Australia. They have recently sent a letter to the government, and I think it was Sweden, one of those Scandinavian countries, saying that they were shifting their drugs over to the vial and syringe system so that they could better supply the U.S. Market. So there's still problems there, and I don't know what's going to happen. We
Yeah.
do know that the drugs, that semaglutide will eventually come out of shortage.
Right.
And at that point, it's going to be based on the judgment of a prescriber as to whether or not a patient needs a different dosage form or dosage strength or combination. And I believe prescribers are well within their rights, and pharmacies
Mhm.
are within theirs in dispensing those drugs. Again,
Mhm.
there's some legal risk from the drug makers swooping in on some of those. So it's going to be interesting to watch.
Yeah.
I do think this idea that Novo and Lilly have been suing mom and pop businesses
Yeah.
is just stunning to me. And it's a surprise, frankly, that more attention hasn't been drawn to that.
Absolutely. Yeah, and they're kind of I think because I think people think of the big boys, right? And they're
Mhm.
not necessarily considering, but here's the thing. If the big boys could handle everybody that had obesity and needs help, they would. But
Yeah.
there are not enough people that understand it. There are not
Mhm.
enough people that are willing to prescribe, mostly because of all of this crap that goes on around it. Physicians don't even want to get involved. Not to mention that what it's like to have to go through to get these, prior authorizations done and keep them and call around pharmacies for shortage. Most physicians don't have that staff. So it's all they're doing is just making more doctors not want to take care of us, which makes it
Well,
harder, which makes people feel desperate, and they will get desperate because when the
well,
food noise comes back and they realize how torturous it is, they will go to these peptide
well.
companies and they will do that, you know?
If you'll allow me a little bit of a rant,
Absolutely. Yeah.
another thing that shocks
Always
me,
rant.
compounding has been savaged by obesity doctors online
Yeah.
and in the media. I have a son. I'm proud of my son. He graduated from medical school at the University of Florida last year. He is a medical resident in Ann Arbor, Michigan.
Mhm.
It's residencies in internal medicine. He went through 4 years of medical school and never heard about compounded drugs.
Wow.
So he graduates from medical school in terms of therapeutic options, medicines, that sort of thing. He's got one arrow in his quiver, and it's FDA approved drugs.
Mhm.
And a lot of folks are graduating from medical school never having heard that they have the ability to customize medications for a
Yeah.
range of conditions. And so we've got a lot of obesity doctors out there that are referring to compounding as quackery and witchcraft, and you can't know what's in a compounded drug, and a bunch of nonsense. It's just not
it is
true.
nonsense.
And I think it's unfortunate because they are shortchanging patients who, in this shortage, could benefit from those drugs.
Yes, absolutely. And I think that's really, really important to think about, right? As we move forward, because I would tell you that that is also the case in terms of treating the disease of obesity. They have like one class. And I think it's like getting better because of all of this, but it's still not good. I mean, even the education of the public, which obviously we're trying to change, but when we've been filming a documentary and we were out, just asking people like, what do you think about GLP-1s and blah, blah, blah. It wasn't until I said to people, tell me what you think about people taking Ozempic for weight loss, that they had opinions. And almost all of them, their opinion, almost all of them was they shouldn't do that. They're taking away from the diabetics. I mean, like the narrative in general around compounds, around obesity in the general public is bad. And think about how many people have obesity. 40+% of America, plus overweight, 70+% of America. It's a huge problem and it leads to so much stuff. And like I said in the beginning, it can easily get to a place where it bankrupts our country. So we've got to find a way to fix it. And that leads into my final question, which was just recently they're talking about PBM reform. And I wanted to see if you have any like insight on that.
I used to work, before this job, I worked for the National Community Pharmacists Association. And of course, PBM reform and all that they steal from patients and from independent pharmacies is ridiculous. On the compounding side, interestingly, we don't deal with PBMs. Compounding, because the compounded drugs are not FDA approved, most insurance companies do not cover them. The overwhelming majority do not cover them. And so there's no reimbursements for PBMs to be involved in. And again, just sort of an interesting aside, we're seeing more of a movement of independent pharmacies into compounding for the very reason that they don't have to deal with PBMs. It's a cash business.
Yes. Yeah, we actually had Forest Park Pharmacy, which is kind of big on TikTok, on our podcast a couple weeks ago. And he was specifically talking about how they've just literally got to the point where they're like, hey, most medications are generic. There's not anything we can do about these branded ones, and we're not going to work with insurance anymore. And like, so they can stay in business,
Yeah, well, we've got a pharmacy, and it's just one among many. A lot of compounding pharmacies are hybrid pharmacies. They're doing traditional retail dispensing and they're doing compounding. Preston's Pharmacy in Arlington, Virginia, the pharmacist in charge there, Scott Welch, was telling me a while back that his compounding operation subsidizes his traditional retail dispensing. He is completely underwater in the dispensing that he does of FDA-approved drugs because of PBMs, but because compounding is cash and he's got a robust compounding business, it's saving the day for the other side.
Wow.
A lot of pharmacies that are in that group.
Yeah, it's a problem. I'm hoping that some things come through that, over the next year or something. We had the CEO of Newmont, and he was very much talking about, I think that over the next few years, like it'll be more like commonplace and all this stuff. But those of us who are older, especially, right, and have these diseases, we're dying now, so the whole idea of waiting for the system to keep up with us, it's an issue. Like, it's easy as someone that doesn't have it to kind of sit back, and that's not any thing to him. Like, their company's really trying to help, I think. But it's easy for that, right, to be that way. So I hope that with what we're doing and what others are doing, continuing to make noise and continuing to like educate, that it will be better. We're doing what we can, so I really thank you for coming on the show today and helping, us give more information to our people. And it's been lovely.
I think so too. You guys are fun. Thank you so much for having me.
Absolutely. Thank you so much.
Thanks for having class or giving class.
Yeah. Roll Tide.
War Eagle. War Eagle.
Roll Tide.
I knew it. I knew you couldn't leave with it.
Oh, there's only one phrase. It's roll, tide, roll.
I'm a Tar Heel over here.
If you were a real Southerner, you would stretch that out into about 12 syllables.
On interwebs, we just say RTR.
Yeah. Thank y'all.
Thank you so
Thank
much.
you.
Thank you, sir. You have a great one and enjoy
Have
your
a great
holiday.
weekend.
All right. Y'all take care.
All right, bye.
Bye-bye.
That was a great episode.
It was great.
That was.
Lots of good information, even though he's War Eagle.
We're going to forgive him his
We'll forgive him.
misplaced college allegiance.
Sure. Smart guy, super helpful. All right, guys. We'll Bear Extraordinaire is gonna go get this edited
We
and
gotta get it in.
and up, and we're gonna get it out because people need this information.
no
now.
editing
I'm gonna make
needed.
shorts, and we're gonna get it out because you deserve. Just please try to remember. I know that this is a time where we can feel very desperate because none of us want to go back, right?
Mm-mm.
We think about, and it's not go back to being in a big body. It's going back to being sick. And so we have to make sure that we're communicating. We have a new administration coming in. We already know some of those people don't know what the fuck they're talking about. So we need to make sure that we are using the proper language as we continue to move forward in our movement, right? For us to be able to get access to quality care, the care that we deserve. Okay.
Yes.
So no more weight loss meds talk. These are medications for chronic diseases. And we deserve them. And you are for sure worthy. Okay. So we're going to put the link that he mentioned in the show notes so that you can go and search to find whatever you need, right? Whatever resource you need to get what you need. And we hope that this has been a help to you. And we love you. And just don't get desperate. It's okay to feel it, but don't make a decision that's going to hurt your body. Okay.
And remember, you're not alone. And it's not your fault.
That's right, Bear the Extraordinaire. Thank you for the close out. Hasta la pasta. We will see you next week.
Bye.
"20 seconds a week to lose 20% of your weight in a year with diet and exercise. That's the power of GLP-1s through Ro. Ro helps find the medication that's right for you, based on cost, availability, and your weight loss goals. Losing weight with GLP-1s is possible through Ro.
Are you interested in understanding GLP-1 medications like Ozempic, Wegovy, or Mounjaro? Then join us on the Plus SideZ Cracking the Obesity Code, the groundbreaking podcast helping people change their lives one episode at a time. The Plus SideZ Podcast is a disruptor. We're breaking down barriers, smashing stereotypes, and sharing inspiring stories that'll leave you feeling informed and empowered. Join us every week to learn from doctors who are specialists around GLP-1 medications like Ozempic, Wegovy, and Mounjaro. They'll provide you with science and facts to validate these incredible stories. But that's not all. We'll also bring you the voices of the GLP-1 Mounjaro TikTok community, real people who face the challenges of obesity-related diseases and disorders and discovered the incredible plus sides of GLP-1 medications. Our episodes are filled with heartwarming stories, laughter, and moments of triumph. You'll connect with our amazing community members who are reclaiming their health and experiencing their fullest lives. Are you ready to embark on a journey of discovery and empowerment? Tune in to the Plus SideZ Cracking the Obesity Code, and together we'll change the narrative around obesity and end the stigma. Subscribe now on YouTube or your favorite podcast platform and join our incredible community. Let's celebrate the plus sides of life together, because every story deserves to be heard. Every life deserves to shine, and everyone deserves access to expert knowledge and medication. The Plus SideZ Podcast. You're not alone. It's not your fault.